All right, noon has rolled around. Let's get started on today's Department of Medicine Grand Rounds. I'm Allison Bond, excited to introduce our two expert speakers for today. We're going to be learning about vasculitis, which I think to us non-rheumatologists often feels like a black box with a lot of nebulous symptoms, and always excited to sort of learn how you all think about that. In particular, today we're going to be learning about imaging as it relates to these diagnoses, as well as treatment, and trying to balance the risks and benefits of immunosuppressive therapies. So by way of introduction, we have Dr. Sharon Chung. She was a rheumatology fellow at UCSF and joined UCSF faculty in 2007, then completed a master's degree in advanced studies in clinical research here at UCSF. She directs the UCSF Vasculitis Clinic, and she's the chair of the American College of Rheumatology Vasculitis Guidelines Development Committee. Also, she's the director of clinical and translational medicine at the Immune Tolerance Network, where she develops clinical trials investigating novel approaches to induce immune tolerance in allergy and autoimmune diseases. We also have Dr. Goglin, who joined faculty here at UCSF in 2009 and practices in the inpatient and outpatient setting at Zuckerberg San Francisco General Hospital. She's the Associate Chief of Education in the Division of Rheumatology at UCSF and the Associate Program Director of the UCSF Rheumatology Fellowship, as well as the Senior Associate Program Director of the Internal Medicine Residency here, focusing on subspecialty education. And in addition to that, she is co-chair of the Rheumatology in Training Exam Task Force. So I'll let you all take it away.
All right, hi everybody. Thank you again for the invitation to speak. It's really such a privilege to be in front of this audience here as well as online, and to get to speak with my teacher and mentor, Dr. Chung, who essentially taught me everything I know about vasculitis since I was a fellow here. So today we decided to talk about updates in large vessel vasculitis, specifically focusing on imaging and therapeutics, as Dr. Bond has said. Neither of us have any disclosures. And our major learning objectives that we're hoping you'll walk away from this hour with are, first, to understand the role of imaging in both the diagnosis and the serial monitoring of patients that have large vessel vasculitis. And I'll be focusing on that piece. And then Dr. Chung will be focusing on the second objective, which is really helping you to identify new strategies to limit glucocorticoid exposure when you're treating patients who have large vessel vasculitis and understanding potential adverse effects of these medications. So I am a clinician first and foremost at heart, and so this talk is really grounded in a case of a patient. So this is a 72-year-old woman who's coming in with several weeks of new occipital and temporal headaches. She's never had a previous history of headaches, and these are really quite bothersome for her. She's also had several months of fatigue, decreased appetite with about 10 pounds of weight loss, which she attributes to stress, and denies any other symptoms, including fever, scalp tenderness, jaw claudication, visual symptoms, shoulder or hip pain or stiffness. On exam, she's well appearing. She has symmetric blood pressures in her arms and her legs and no carotid bruits. She also has no tenderness to palpation of her temporal arteries. And her laboratories are notable for an elevated ESR of 62, as well as an elevated C-reactive protein. So before we dive into talking about updates in large vessel vasculitis, I just want to make sure that we're kind of all starting from a similar place of understanding of the systemic vasculitis in general, because I recognize that although this is something that we think about on a daily or weekly basis, this is not something that most of you think about frequently at all. So if you remember back to medical school or internal medicine training, you might remember that we organize a framework for the different types of systemic vasculitis by the vessel size that they tend to affect. And we divide this into small, medium, and large size blood vessels. For the purposes of today, we're really going to focus, as we've said, on large vessel vasculitis. And the two main diseases that fall into this category are giant cell arteritis and Takayasu arteritis. We're going to focus primarily on giant cell arteritis because it is much more common than Takayasu arteritis is, but actually a lot of the things that we will discuss do have corollaries in Takayasu arteritis as well. And also by way of orientation, so in addition to thinking about vessel size, we think about the typical vessels that are affected and then the clinical manifestations that go along with those. So in our large vessel vasculitides, it's usually the aorta and branches of the aorta that are affected, the carotids and the extracranial branches of the carotid in giant cell arteritis in particular, and subclavian and iliac vessels as well. And so in our patients that have large vessel vasculitis, symptoms that we commonly see are headache. Patients may experience vision loss, which is a feared complication of giant cell arteritis, chest pain, vascular aneurysms, especially aortic aneurysms, and then symptoms of claudication in their extremities. So for giant cell arteritis, this is a granulomatous arteritis, as I've talked about, of the aorta and its major branches, and it has this funny predilection for the cranial branches of the carotid as well as the vertebral arteries. And that impact on the cranial branches of the carotid are what gives it its name of temporal arteritis, because of the fact that this disease often affects the superficial temporal artery, and that's what gives the symptom of headache that many, but not all patients will present with. This is a disease of older individuals, so the average age of onset is in the 8th decade of life, and it has its highest incidence in people who are of European ancestry, but can affect people from all different types of ancestral backgrounds. And then one of the reasons that we're highlighting this disease today is because it is the most frequent type of systemic vasculitis. So even as a non-rheumatologist, you will definitely take care of patients who have giant cell arteritis or in whom you suspect this diagnosis if you're in a primary care or emergency room setting. And one of the things that I want to make sure is clear as we dive in to talk about imaging specifically in this disease is that giant cell arteritis is not just temporal arteritis. And so really trying to get away from using that name as we're making this diagnosis, because while it certainly does affect the cranial arteries in the majority of patients, there are patients who have just isolated large vessel or aortic involvement, and that's the large vessel involvement is highlighted in this image from a PET scan here of a patient who had really diffuse large vessel involvement. Patients may present just with isolated fever of unknown origin, and then there are several atypical features of giant cell arteritis as well that patients may present with. So important to recognize that there is a spectrum of the way that patients will present with this disease, and that informs kind of how we think about diagnostics and monitoring for these patients going forward. So the first question that you might be asking yourself based on the STEM that I've presented is, does my patient have giant cell arteritis, and what are the diagnostic modalities that are available to me to try to understand the answer to that question and make a diagnosis? So just kind of, this is a thought question, not something that I'm asking the audience, but things that you might consider as a next step in diagnostic evaluation when you're seeing a patient like this would be, number one, getting a temporal artery biopsy, which we are all familiar with. Number two, getting an ultrasound of the temporal and or the axillary arteries. Number three, getting a high resolution MR angiogram of the cranial vessels. And then number four, incorporating a PET scan in addition to low dose CT to look at those cranial vessels. So let's talk about some of these in a step-by-step fashion to understand the pros and cons of these different diagnostic approaches. So just a few words on biopsy. So probably most people in the audience recognize temporal artery biopsy as the historical gold standard for making the diagnosis of this, incorporating this information with clinical context, of course. Ideally, when we're obtaining a temporal artery biopsy, we're doing it within the first couple of weeks of starting someone on prednisone for the suspected diagnosis, although there is a role for later biopsies as well. And because the pathology here often includes skip lesions, it's important to ensure that you're getting a sufficient size sample when you're referring a patient for biopsy. So ideally, greater than 2 centimeters. There's sometimes a debate about whether to start with a unilateral versus do bilateral biopsies up front. Typically, we will start with one side, but may pursue the contralateral side for a biopsy target as well if the initial biopsy is negative. And we know that up to a quarter of patients who have an initially negative biopsy will have a positive biopsy on the contralateral side. The sensitivity of temporal artery biopsy is not perfect. So some studies as high as 90%, but many more lower than that. And so again, we are always incorporating this information in the context of the signs and symptoms of the patient in front of us. And this is just a pathology slide showing active temporal arteritis with this transmural mononuclear cell infiltrate and giant cells present there in the inset panel. So how do we think about now advances in imaging that have occurred and how they might help us in making the diagnosis and potentially avoiding the need for biopsy in some patients? So let's talk about ultrasound first. So there has been a great deal of interest in using color Doppler ultrasound of the temporal as well as the axillary arteries and making a diagnosis of giant cell arteritis. And things that the ultrasonographers and radiologists are looking for include stenosis, occlusion, and then what's called the halo sign, which is shown here in the transverse section and then here in the longitudinal section. And this is this concentric hypoepigenic mural thickening. While I wish that this were something that we had available to us here and kind of broadly throughout the United States, that is not the case. So this is now in Europe, the gold standard for making the diagnosis of giant cell arteritis, but for a variety of reasons, that has not translated to our centers yet. And so it's very important to recognize this. In most United States centers, this does not replace the need for a temporal artery biopsy because people do not yet have the training and subsequent expertise that comes with this in making this diagnosis. And that includes us here at UCSF, as well as at San Francisco General and the VA. So we would not recommend this as a diagnostic tool to replace temporal artery biopsy in a patient in whom you suspect giant cell arteritis. Hopefully we will get there, and the data coming out of centers where they do have a lot of expertise in this is fantastic, but we're not there yet. So the second imaging modality that we are using with relative frequency in the evaluation of patients with giant cell arteritis is a contrast-enhanced high-resolution MRI of the temporal and other cranial arteries. This slide here is courtesy of Dr. Leach, who's in the audience, showing some of the characteristic features that the radiologists are assessing for when they're looking at the temporal arteries. So you can see here in the first panel, on this time of flight MR imaging, the narrowed lumen with T1 weighted imaging the thickened wall of the temporal artery. And then finally, when gadolinium is added, you can see the inflammatory enhancement that surrounds and kind of goes through that vessel. So this has been looked at in a variety of studies. And I think the major takeaway, and I've shared with you the data from the largest study that assessed this in just over 170 patients, in which they did MR imaging in all of these patients, as well as temporal artery biopsies. And using that and clinical information, we're able to calculate negative and positive predictive values for these studies. The big takeaway is that these images have great negative predictive value. So approaching 100% in this one study, which has been replicated in others. But the positive predictive value was only about 48% in this trial. So a coin toss. So what does that mean for us as we're using these images and interpreting them in the context of patient care? So they are helpful to rule out giant cell arteritis when you have a patient in whom you have a relatively low or low to moderate pretest probability of disease. So if you have a patient, you get this MR angiogram, it is completely normal. In many situations, you can feel comfortable not referring that patient on for a temporal artery biopsy. But the converse is not true. So if you get an abnormal study, at least in the current state of this kind of technology and expertise in interpreting this imaging, an abnormal study should prompt a referral for a temporal artery biopsy to try to make a definitive diagnosis. The other thing that's really important to recognize is, just like with the ultrasound, the experience of the radiologist in interpreting these scans and the volume that's being done in the specific center is very important to know if what is being reported from these studies is something that you can translate into your clinical care. We are extremely lucky here. We have wonderful neuroradiologists that have a lot of expertise in this. And so when these studies are protocoled correctly, I really trust the interpretation that we're getting from our radiologists, but that's not the case everywhere. The other thing that's really important to know is that the changes, the abnormalities on these scans go away very quickly once we start prednisone. And often we are starting prednisone at the time that we're evaluating these patients because we are concerned about the possibility of vision loss developing. And so if you're going to get this imaging study, you need to interpret the results in the context of whether or not they've been started on prednisone and how long they've been on it. So if you have someone with classic symptoms, they've been on prednisone for 7 days, then you get this MRI and it's normal. That is not the situation in which you're going to be ruling out giant cell arteritis based on that information. So the ideal scenario, and often what we're able to do here at UCSF, is if we see a patient in whom we suspect this, we can send them to the CDU in the emergency department, that they can get that MRA there, be evaluated by our consult service, and kind of all of this happens in a perfectly synchronized way, which I realize is not always true, but the ideal state. So just to wrap up a little bit of this section, I just want to highlight a couple of points from the American College of Rheumatology guidelines on the management of GCA and Takayasu's that were published several years ago, which highlight what I was just talking about. So in the United States, temporal artery biopsy is still recommended for making a diagnosis of giant cell arteritis over temporal artery or axillary ultrasound and over MRA. So MRA has a great role in ruling out disease, again, in the appropriate clinical scenario. All right, so back to our patient. So she undergoes a temporal artery biopsy, which reveals transmural inflammation with giant cells present, and she's diagnosed with giant cell arteritis. She's then started on treatment with prednisone and a steroid-sparing agent, which Dr. Chung is going to talk more about, and has resolution of fatigue and her headache. So now a question that we ask ourselves is, does the patient that you're taking care of and whom you just established a new diagnosis of giant cell arteritis need any additional diagnostics? And the reason why this question comes up is, again, because this is a disease that doesn't just affect the temporal arteries. So large vessel extracranial involvement is common, and patients can develop stenosis, aneurysm, and dissection of the large vessels when they are affected. So knowing that about them is important in providing care for these patients. It may not change how we think about therapeutics for them up front, but it certainly does change our monitoring for them over time. The prevalence of extracranial large vessel involvement varies from study to study, depending on the modality that's being used to evaluate for this, so ranging from 1/4 to 2/3 of patients when CTA is used up to 100% of patients on autopsy studies having large vessel involvement. These manifestations are highest within the first several years of diagnosis, so any large vessel within the first year, and then aortic aneurysm and dissection, which are complications of the aortic involvement within the first 5 years of diagnosis. And so this is really why knowing about this matters. These patients who have aortic manifestations especially are at significantly increased risk for mortality from this. And so evaluating for this, making this diagnosis, and then following them from a disease activity standpoint, which I'll talk about, and the potential need for surgical intervention is very important. So again, to share some really nice images here from Dr. Leach in terms of what we're looking for when we get MR angiography in these patients. So these are images from a patient who had abdominal aortic involvement. And the first thing to point out is, again, this is a patchy process. So this patient has part of their abdominal aorta that's affected, and then another part down here that's normal. So it provides kind of a nice internal compare and contrast. So if you zoom in here on this part of the abdominal aorta, what you'll notice, and what Dr. Leach highlighted nicely for us, is that There's inflammatory peri-aortic involvement here, which is colored in blue, as well as inflammatory mural enhancement that's seen, which is colored here in red. And that's in comparison to another segment of the abdominal aorta that's not affected. And so these are the kinds of abnormalities that we're looking for when we get these imaging studies in patients. And our general practice when at diagnosis is to scan them from their neck through their pelvis, and then depending on what we find, following them serially from there. And this is also highlighted in the ACR guidelines for GCA management. So in patients that have newly diagnosed GCA, it is recommended to get non-invasive vascular imaging, again, to screen for this large vessel involvement for the reasons that I mentioned. Another question that commonly comes up and that I'm not going to spend a lot of time talking about is what type of imaging should we be getting initially when we're looking for large vessel involvement? I will say that our preferred practice is to obtain MRI angiography in these patients. CT angiography also does an excellent job of assessing for large vessel disease, but because these patients often need multiple studies over many years, we prefer to get an MRA up front so we can follow that over time. And so they don't have ongoing repeated exposure to radiation from the CT angiography. Ultrasound really does not give us the resolution that we need to look carefully at the aorta and its branches. So that is not preferred. And I'll talk about PET in just a minute. All right, so back to our patient. So she gets an MRA, as I mentioned, which reveals multiple abnormalities in her large vessels. She gets started on treatment, and then 6 months later, she has repeat imaging done, which shows improvement in the contrast enhancement that was seen in many of those vessels. But she is noted to still have some persistent wall thickening in the descending aorta. And so this brings up the question of how do we assess disease activity in patients that have large vessel vasculitis? What do we do when some of these abnormalities persist over time? Does it reflect unchecked inflammation or not? So as I've hopefully, kind of emphasized for you all, non-invasive angiography is really essential in taking care of these patients, both from detection and then ongoing monitoring of vascular changes that we may see. But the changes can persist over time and don't necessarily reflect active inflammation. So there's increasing interest and research in the area of multimodal imaging assessment. So combining PET imaging with either MR or CT to give us a better understanding of the presence or the absence of inflammation and helping us make treatment decisions for patients. This is very much an area that is not well understood to this point, and in which there's a lot of ongoing active investigation, especially out of the NIH. So just to show you a little bit of data here, this is from the NIH, a prospective cohort of 70 patients. These patients had GCA as well as Takayasu's arteritis, and they all got baseline non-invasive angiography combined with a PET, and then were followed over time, but only for an average of about 1.5 years, so not long follow-up. And really the main point of this study was to evaluate the association or lack thereof between the baseline PET activity in their large vessels and then their risk for subsequent angiographic change or damage over time. And the top line results for this is that the lack of PET activity at baseline was highly associated with stable angiographic disease over time with a negative predictive value of almost 100%. So if you had a patient whose PET was normal, was cold at the beginning, none of them went on to develop progressive vascular involvement or vascular damage in the subsequent follow-up period. So this and other studies have continued to spark our interest and our use of PET to help us kind of make this decision about whether or not patients are at risk for ongoing disease activity or have ongoing disease activity, but we're still really understanding how to use this information. So I'll end here with some unanswered questions that remain about serial imaging in patients that have large vessel vasculitis. So the first is I just told you that we have some helpful information now, helpful data to guide us based on normal PET findings, but we still don't really know what an abnormal PET means in these patients. So actually the majority of patients who had PET activity in their arterial territories in that same study also didn't go on to develop angiographic change over that follow-up period. We are also learning how to use the PET in combination with the non-invasive angiography information that we get from the MRAs. So there are some data that when patients have focal asymmetric PET activity and then on angiography in that same territory, have ongoing wall thickening and enhancement in edema, that those are the patients that are at highest risk. So maybe those are the ones that we should target for therapeutic changes. But again, still not an answered question. And then what are our goals? So in patients that are clinically doing well, they feel great, they have no symptoms, but we continue to see some PET activity on these images. We should not necessarily be trying to treat them until that PET activity goes away. We don't have data that necessarily benefits all patients, and we may be exposing them to undue, risk of harm from immunosuppressive medications. And then finally, the unanswered question is, how frequently do we need surveillance imaging in patients with large vessel involvement? We certainly have our own local practices here, but this is an area in which there is not a good evidence base at all. And then finally, I just want to give a shout out to Joe Leach, who actually is in the room. He's been an amazing partner in helping us improve the care that we provide for patients with large vessel vasculitis due to his expertise in vascular imaging. So prior to his involvement, our patients used to have to come for 2 to 3 scans on different days for us to be able to capture all of the vascular territories that we needed to look at. And even with that, we still didn't always get the information that we were hoping to. And so he has done really a wonderful job of optimizing a protocol that allows us to look at all of the vessels from the neck kind of through the top of the thighs, really in a single scan, optimized for large vessel vasculitis, whereas the previous scans weren't necessarily doing that, and even see some smaller branch vessels as well. So thank you to Joe for his partnership. And now I'm going to turn it over to Sharon to talk about treatment.
Kudos to Joe, who thinks he's great, such that they don't have to deal with the terrors of coming to Parnassus for their imaging on multiple days. So thank you, Sarah. My name is Sharon Chung. I am an adult rheumatologist. I am a proud, what I would call vasculitisologist. And if I could convert anyone in the audience to be vasculitisologists with me today, I'd be extremely happy. It is a great time to be a rheumatologist and a vasculitisologist, if I may say so. All right, so I have the fun responsibility to talk about treatments for large vessel vasculitis, and as Sarah mentioned, we're focusing on giant cell arteritis today. I suspect all of us had to learn about treatment for giant cell arteritis for our boards and what is taught in medical school, and to our residents and to our rheumatology fellows is that if you suspect a patient has giant cell arteritis, you need to start them on prednisone right away. And as Sarah mentioned, the reason we do that is we're concerned about vision loss. Vision loss occurs quickly, abruptly in patients with giant cell arteritis, is frequently irreversible. And if you have one eye affected, it is not unusual to subsequently develop vision loss in the second eye. So that is why we're very gung-ho about starting patients on prednisone. Now, for patients that, Sarah presented, with headache, constitutional symptoms, without, visual symptoms, we usually start them on high-dose prednisone, so 40 to 60 milligrams a day, single dose, and then we taper. For somebody that we're concerned that may have experienced vision loss or has threatened vision loss, some changes in their vision, we talk about pulse methylprednisolone, so 500 to 1,000 milligrams a day for 3 days, and then switching them over to high-dose oral prednisone. And if for patients who don't have access to pulse methylprednisolone, we do high-dose prednisone, so 1 milligram per kilogram per day. The big question is duration of treatment. And honestly, with prednisone monotherapy, we really don't know the optimal duration of treatment, but it's pretty typical for patients to be treated for at least 12 months, up to, for example, a year and a half. So we start off at high dose, either pulse or, 40 to 60 milligrams per day. The goal is to get them to 10 milligrams per kilogram, 10 milligrams per day by about 20 weeks, and then a slow taper after that. But let's be honest, I don't have a single patient in my practice who goes, yay, prednisone, at the thought of being started on this therapy. And this is because prednisone has known side effects, and they are incredibly impactful on a patient's life. So this includes weight gain, insomnia. My patients become either manic or depressed. They can develop cataracts. They can develop elevated blood sugars, and they can develop osteoporosis, and the list goes on and on and on. So these side effects are most prevalent when patients are being treated with moderate to high doses, so greater than 20 milligrams a day. As I said, they have a significant impact on our patients' quality of life, and some of these side effects are irreversible. For example, the osteoporosis and the cataracts are generally considered irreversible. So a lot of the energy in the vasculitis field has been focused on, can we identify steroid-sparing agents for giant cell arteritis? Can we decrease the prednisone exposure for these patients to improve their quality of life? And I would say that the field or treatment practices and the field changed dramatically in 2017 when the GIACTA study was published. So GIACTA was a randomized placebo-controlled trial that investigated the efficacy of tocilizumab compared to placebo in combination with a 26-week prednisone taper in patients with giant cell arteritis. Now, I suspect most of you in the room are not prescribing tocilizumab, which then begs the question, what is tocilizumab? Tocilizumab is a monoclonal antibody directed against the receptor of interleukin-6. So interleukin-6 is a pro-inflammatory cytokine, and it was identified as a potential target for patients with giant cell arteritis because IL-6 is actually identified to be elevated in the lesions of biopsies that showed temporal arteritis. And it's also the serum levels of IL-6 are elevated in patients with GCA. So that's why tocilizumab, as an IL-6 receptor inhibitor, was looked at for potential treatment for giant cell arteritis. It binds to both the soluble form of the receptor as well as the membrane form of the receptor. And by binding to the receptor, it prevents subsequent signaling through the JAK-STAT pathway, which can lead to pro-inflammatory conditions. Now, tocilizumab was actually initially approved for inflammatory arthritis. So most of our experience with tocilizumab is in rheumatoid arthritis, but it's also used outside of kind of the rheumatologic realm. So for those who are on the hematology oncology side of things, you may have familiarity with tocilizumab as one of the main treatments for cytokine release syndrome that can be seen with CAR T-cell therapies. And we can also, it's also approved to treat the complications of COVID-19 infection in hospitalized patients. In the rheumatology world, we also use it in other diseases such as systemic sclerosis. So the GIACTA study design utilized 2 doses of tocilizumab. So tocilizumab is a subcutaneously administered drug. So it utilized tocilizumab with weekly dosing and also every other week dosing in combination with a 6-month prednisone taper. And then it compared it to 2 placebo groups. So one placebo group which received a 6-month prednisone taper, and then another placebo group which used a 12-month prednisone taper, which is more commonly done in clinical practice. And the primary endpoint was sustained remission at 52 weeks. And what got everyone really excited was the differences in sustained remission seen with tocilizumab use. So for the patients who were on tocilizumab, about over 50% of them had sustained remission from weeks 12 to 52, compared to only 14% of those who were on a 6-month prednisone taper. And the other aspect of this was that we saw a significant decrease in glucocorticoid exposure. So the cumulative prednisone exposure for patients who are on tocilizumab with their 6-month prednisone taper was about half compared to those who were just on prednisone alone. I'll give you the Kaplan-Meier curve that shows, the proportion of participants without a flare while on tocilizumab. So these top two lines here that have the weekly and every other week dosing of tocilizumab show a significant decreased rate of relapse compared to those who were on the 12-month prednisone taper or the 6-month prednisone taper. And based on the studies, the findings of this study led to our recommendation in the guidelines that Sarah has introduced us to, that for patients with newly diagnosed GCA, we conditionally recommend the use of oral glucocorticoids with tocilizumab over oral glucocorticoids alone. So really pushing the idea of using steroid-sparing agents in our patients to decrease the toxicity of glucocorticoid exposure. Now, I don't necessarily expect you as internal medicine physicians and practitioners to prescribe tocilizumab, but I would not be surprised if you at some point during your training or career have patients on tocilizumab in your practice. So what do you need to know about tocilizumab? Tocilizumab is an immunosuppressant and increases, someone's risk of infection. I think that's obvious and a bit of a no-brainer. But I think it's important as, internal medicine practitioners to recognize the impact of tocilizumab on inflammatory markers and on the risk of gastrointestinal perforation. So, tocilizumab and acute phase reactants. The most common acute phase reactants or inflammatory markers that we assess in our clinical practice is the ESR, erythrocyte sedimentation rate, and the C-reactive protein. And I'm pretty sure someone has spoken to you in the past about the ESR. You draw blood up in the capillary tube, and in the olden days, we would tape the capillary tube to the wall and see how far the red blood cells would drop, and that would give us our erythrocyte sedimentation rate. How much did those red blood cells drop in the first hour that you hung it up on the wall? The ESR is actually not an assessment of one inflammatory marker. It's kind of a global assessment of inflammatory markers in the blood. So for example, we're all taught that, there's C-reactive protein is an acute phase reactant, and ferritin and haptoglobin, on all these other things. The ESR is kind of a global assessment of all of those acute phase reactants. It's kind of like a CH50 for complement. Now, one of the main contributors and one of the major acute phase reactants in the blood is the C-reactive protein. So that itself is a specific acute phase reactant. And the CRP contributes quite a bit to the information identified in the ESR. Now, C-reactive protein, CRP, is produced directly from hepatocytes upon stimulation for IL-6. And so patients on tocilizumab will have a decreased CRP and probably an ESR, independent of what their disease activity is, independent of what else is going on in their body. And it's because the tocilizumab interferes with IL-6 signaling through the hepatocyte, and so the hepatocyte is no longer producing C-reactive protein. So what does this mean to you as, an internal medicine practitioner? It means that the ESR and CRP are suppressed for patients on tocilizumab. So, if you're sending an ESR CRP to help assess for infection or other inflammatory states, this test is going to be pretty uninformative. So just remember, patients on IL-6 inhibition are likely going to have normal acute phase reactants independent of what else is going on in their body. Now, what's also not intuitive is that IL-6 actually has a role in maintaining your gut epithelium. So IL-6 is produced after intestinal injuries. It induces epithelial proliferation in the gut. It prevents epithelial apoptosis. It can regulate permeability of the tight junctions of the gut epithelium. And during development of tocilizumab, it was noted in clinical trials that there were patients who developed lower intestinal perforations. And so this led to to a plethora of registry studies, the results, one of which are shown here. So this is a German registry called RABBIT. It is a registry of rheumatoid arthritis patients started on biologic therapy, as well as conventional synthetic DMARD therapies such as methotrexate. And what you can see here is that the rate of GI perforation for tocilizumab compared to other therapies that we commonly use in rheumatoid arthritis is much higher. And there are risk factors for developing GI perforations on tocilizumab. They include a history of diverticulitis, an older age, concurrent glucocorticoid use, so for example, prednisone more than 7.5 milligrams per day, and concurrent nonsteroidal use. What I think it's important to know about GI perforation and tocilizumab is that these patients often present with milder symptoms. So we think about GI perforation, patients have an acute abdomen, they're in severe pain, they're unwilling to move, they often have elevated inflammatory markers. A lot of this actually doesn't apply to patients on tocilizumab who have GI perforations. They usually present with much milder symptoms, much less pain, and because they're on tocilizumab, their inflammatory markers tend to be much lower, or their C-reactive proteins tend to be much lower. And I think because of this, this often leads to a delay in diagnosis, which actually can contribute to the increase in mortality that we see in patients who develop GI perforations on tocilizumab. So in this German RABBIT registry, out of the 16 patients who developed diverticulitis, 11 of them developed lower intestinal perforation, and 5 of them died. So that's a mortality rate of approximately 50%. I recognize that these are small numbers, so we shouldn't extrapolate too much, but just to understand that patients on tocilizumab can develop significant GI complications that don't present in the typical classic way, and this may lead to a delay in diagnosis, which affects their mortality. I'll finish up with one other study. So last November at the American College of Rheumatology meeting, we got very excited because there was a potential second steroid-sparing agent identified for giant cell arteritis. And this is because the SELECT-GCA study, results of the SELECT-GCA study was presented. So SELECT-GCA assessed the efficacy and safety of upadacitinib versus placebo in combination with a glucocorticoid taper regimen in patients with giant cell arteritis. So, extremely complicated name, upadacitinib. What is it? So, it's a JAK kinase inhibitor, and specifically a JAK kinase 1 inhibitor, or a JAK inhibitor. So, what are JAKs? JAKs are part of the signaling cascade, the intracellular signaling cascade that is triggered with the binding of pro-inflammatory cytokines. IL-6 was one of the ones that I mentioned earlier. Here's another group. They're also involved in the pro-inflammatory milieu induced by type 1 and type 2 interferons. There are lots of different types of JAK inhibitors. They bind to different JAK enzymes, so JAK1, 2, and 3. Some are more JAK1 selective, such as upadacitinib. Others bind to all 3 of them, such as tofacitinib, and they've all been approved for a variety of indications. So we have the most familiarity in rheumatology with using JAK inhibitors in inflammatory arthritis, but they're actually used outside of classic rheumatologic conditions. So for example, JAK inhibitors are incredibly effective at inducing hair regrowth for patients with alopecia areata. It can induce skin repigmentation when used topically for vitiligo. It's used in inflammatory bowel disease, and it also has an indication for use in managing COVID-19 complications in hospitalized patients. In the SELECT-GCA study, similar to Giacta, they looked at 2 doses of upadacitinib. So this is an oral medication, 15 milligrams a day versus 7 and 7.5 milligrams per day, combined with a 6-month prednisone taper in comparison to a placebo arm that received a 12-month prednisone taper. And this is kind of the top line results. So the proportion of patients who had sustained remission from weeks 12 to 15 was about 40% in the 2 upadacitinib arms compared to about 29% in the placebo arm. And this is the Kaplan-Meier curve showing the proportion of participants without relapse in the study. So the upper two arms are the patencidnib arm, and the gray arm is the placebo arm. So not as striking as the tocilizumab study, but still evidence of benefit for our patients with giant cell arteritis. So as an internist, what do you need to know about JAK inhibitors? So this is the black box warning that's seen for JAK inhibitors. If you go to the FDA prescribing information, these medications are immunosuppressive, so it's not surprising to see warnings for infections. But for JAK inhibitors, you'll also see warnings for major adverse cardiovascular events, or MACE, malignancy and thrombosis. And this is in comparison to TNF inhibitors in patients with rheumatoid arthritis. So how did this come about? This came about because of tofacitinib. So tofacitinib was one of the first JAK inhibitors that we used in rheumatology. It affects 3 JAK enzymes shown here. And during drug development, they saw increased lipid levels in cancers in their patients treated with this. And so upon approval of JAK inhibitors, the FDA actually mandated a prospective head-to-head safety study looking at tofacitinib with TNF inhibitors to understand this risk further. And that study was the oral study, which was published in the New England Journal about a little over 2 years ago. And it was a randomized open label non-inferiority trial of patients with rheumatoid arthritis who had at least one additional cardiovascular risk factor. They were randomized to one of two doses of tofacitinib or in TNF, and the co-primary endpoints were major adverse cardiovascular events and cancers. Their threshold for non-inferiority would be met if the upper bound of the 95% confidence level was less than 9.5. And what I have here are the results for major adverse cardiovascular events. And what you can see is that for both doses of tofacitinib, the upper bound of the confidence level is greater than 1.9. So tofacitinib is not considered non-inferior. I know there's a double negative there, but go with me on this. And what they showed was the number needed to harm over a 5-year period compared to a TNF inhibitor was about 60 some odd individuals, and the 10 milligrams BID arm, and a little over 100 individuals in the 5 milligrams BID arm. So some evidence that tofacitinib increases major adverse cardiovascular events. And then this was the finding for malignancy. So the upper bound of the 95% confidence level was greater than 1.9. So tofacitinib is not inferior to a TNF inhibitor when it comes to these risks. And approximately 50 some odd individuals would need to be treated for a 5-year period to have an additional event of malignancy. So what can we say about this? So we can see that there's an increased incidence of major adverse cardiovascular events and cancers for a particular JAK inhibitor, tofacitinib, compared to TNF inhibitors. This led to a black box warning being applied to all JAK inhibitors, but it's really unclear if this risk is the same across all JAK inhibitors since they have different targets. It's also not known if the risk is similar in other groups. So this was studied in rheumatoid arthritis, and we don't know what the risk would be for patients with alopecia or other diseases. And we also don't know what the risk is compared to an untreated population. So we know in rheumatoid arthritis, there is an increased risk of cardiovascular events and in malignancies that's associated with rheumatoid arthritis alone. And we don't know how JAK inhibitor use modulates that risk. There's also a black box warning for thrombosis. This study was not intended to study thrombosis, but they saw an increased risk of pulmonary embolism in patients treated with tofacitinib, as well as increased mortality associated with that. So that in part led to the black box warning on thrombosis as well. So I'll finish up here with some takeaways. So with Dr. Goglin's talk, we're seeing that vascular imaging is a really exciting and evolving tool, diagnostic tool for the evaluation of patients with suspected large vessel vasculitis. We're using at UCSF more high resolution MRA of the cranial vessels to assess the risk of GCA, which can be really informative if you have a low to moderate probability of disease. We're hopefully increasing experience with the use of ultrasound in this country so that we can employ it more widely as they do in Europe. And really, as Dr. Goglin mentioned, multimodal imaging is the way we're going. So we can get different pieces of information to help assess disease activity. For me, I think it's really exciting to see that we have steroid-sparing agents being identified to treat GCA, but there is no free lunch in the world and they carry risk. So I think for tocilizumab, it's really important to recognize that they suppress ESR and CRP and can be associated with GI perforations. And for the JAK inhibitors, we have signals of potential increased risk in cardiovascular events, malignancy, and thrombosis, but how widely it applies to all medications in this category is unclear. So with that, I'll end and say thank you to many, including the awesome division of rheumatology that is shown here on the screen. And then I think Sarah and I are open for questions.
Great, thank you so much. That was really a tour de force in updates. And there were a couple of really great questions actually from the chat that I'll start with, and then have a couple of my own, and then I'll open it up to the audience. One is a question from Dr. Flanagan from Vascular Surgery. And they were wondering, they're sometimes consulted for temporal artery biopsy. And so if a team reaches out to them, would you recommend actually having them pursue imaging first? And there's two parts to the question, sorry. Second one is, if they have a high index of suspicion for GCA, do you recommend that they undergo the MRA protocol for multiple vascular territories at once, or just start with the head?
Great.
Yeah, thank you. That is a great question. So I would say that in terms of using imaging up front as part of the diagnostic workup, if your suspicion is high for giant cell arteritis, you have an elderly person, high inflammatory markers, new onset temporal artery headache, and jaw claudication, you're just delaying what they ultimately need by getting interval imaging before a temporal artery biopsy. So I would say in that scenario, no, I would not recommend an MRA. It's very helpful, and what we get asked all the time, you have a 51-year-old woman who comes into the emergency department. They've had like a few months of kind of vague headache, and then someone checks the SED rate and it's like 50, right? So that's the scenario in which your suspicion for giant cell arteritis is relatively low, and that is someone in whom I would recommend an MRA prior to a consultation with vascular surgery for a temporal artery biopsy. So I think it depends. And then in terms of the subsequent question about follow-up imaging, or kind of all over vascular imaging versus just cranial imaging to start, I would say it depends on the symptoms that the patient is having. So if they are having claudication or chest pain and you're worried about large vessel vasculitis, then getting an initial set of large vessel imaging would be indicated. But just as part of the kind of first step of diagnostic imaging, I wouldn't recommend large vessel imaging.
It's not emergent.
Yeah, great point. So unlike the ophthalmologic complications, these other complications that we're talking about from large vessel extracranial involvement take time to develop. You have time to do that diagnostic workup.
Great, thank you. And another great question from the chat, which is, you talked about systemic imaging to look for like large, AAAs and things like that. How does that change management if you find it?
Yeah, so I would say it doesn't change management in terms of choice of medications or dose of medications that you would start up front. It changes how you're going to monitor and follow these patients over time. So if I know that someone has large vessel involvement, then I will follow their imaging serially over time. I will use that information as part of my overall assessment of whether or not their disease is controlled. And then in people who do develop abdominal aortic aneurysms, for example, making sure that that's being monitored so they are referred appropriately if necessary for surgical involvement. So it's really a monitoring piece that's most important.
I think there's a great debate as to whether or not patients with large vessel involvement, like aortic and subclavian involvement, et cetera, should be treated more aggressively. If somebody is not on a second agent, like a steroid-sparing agent, when this is identified, we often do add it, but that is more kind of gut instinct as opposed to being evidence-based at this point.
Wonderful, thank you. And my last question, I think you talked about the tocilizumab plus steroids and that sort of performing better than steroids alone. Are there select cases where you still do steroids alone, or should that be the monotherapy be pretty uncommon at this point?
So I got so much grief for putting out the recommendation of considering tocilizumab up front. I think it depends on your patient and comfort level with risks and benefits. I think as rheumatologists, we've seen an extraordinarily high burden of glucocorticoid-induced toxicity. And because of that, we're very eager to decrease glucocorticoid exposure. If you have a patient who doesn't want to start a second medication, that's okay. The world is not going to end. They're going to be on a slower glucocorticoid taper. They're going to have a higher, glucocorticoid exposure. But for some of my patients, the idea of injecting something into themselves weekly or every other week does not fit in their life. And so I think we definitely do have patients who are on glucocorticoid monotherapy. But I think the important thing is to know that that is not the only option you have out there, and that there are interventions we can use to decrease that potential toxicity.
Thank you. So should PCPs be prescribing tocilizumab?
You have thoughts?
Yeah, we were talking about this before the talk, actually. I think it honestly depends on access to rheumatology care, right? We are very lucky here in San Francisco and at UCSF to have access to rheumatologists, but that is definitely not the case in large parts of the country. One of our colleagues does a lot of work with education around rheumatoid arthritis for primary care doctors who provide care at various Indian Health Services sites. And so those primary care doctors are prescribing a lot of these biologics in the setting of rheumatoid arthritis. So I think you could think about something analogous in the context of giant cell arteritis, again, because it is relatively common in the world of vasculitis. And this is something that primary care doctors definitely are taking care of, without the assistance of us. So one of my missions in education is to help.
And I think it's also important to know that these other agents that I talk about, like tocilizumab and upadacitinib, these are not emergent medications. Like the emergent medication is prednisone, and patients need to be started on prednisone. Whether or not a patient is started on tocilizumab a week later, 2 weeks later, a month later, in the grand scheme of things, is not that big of a deal. But it's the prednisone that needs to be started right away.
Great, thanks. Opening it up to the audience. Anybody have questions? What questions do you have? Great.
Thanks. That was a fantastic talk. I learned a lot. I have a very practical question. I heard that vascular surgeons said sometimes they're asked to do biopsies. I've seen at other institutions, neuro-ophthalmology, plastics, like how do we physically get the biopsy?
I think what you see is also what happens here at UCSF. There are a number of different services that can do it. Vascular surgery has done it for us. Ophthalmology has done it for us. ENT has done it for us. General surgery has done it for us. I don't think thankfully, it's not just one specialty that does it. So it's actually often trying to figure out who has the availability to do it in a relatively quick fashion.
Yeah, I would say in my experience, ophthalmology really only does these biopsies if the patient has suspected ophthalmologic involvement. Otherwise, they generally won't do them, which is fine. At the general, we have now a great relationship with our ENT colleagues there, and really kind of like a fast track to getting patients for biopsies. So for those of you taking care of patients there, that would be what I would recommend.
Thank you. I think we have time for one more quick question. Anybody? Or I'll ask, are you, what's the status of PET CTs with new diagnoses? Is that research only, or are you sending people for PET CTs?
We are getting them in patients in non-research settings. I would say that depending on the patient's insurance, there can sometimes be challenges in getting the PET approved, without a diagnosis of a malignancy. But I would say I've had increasing success with that as each year goes by, and there's more of an evidence base for this in large vessel vasculitis. I think the thing that we're really excited about, and perhaps, with Joe, once the MRA protocol is totally worked out, is then working with our nuclear medicine colleagues to streamline the PET MR ordering, because that's not something from a logistical standpoint that's easy to do yet.
No, it's becoming surprisingly, increasingly easier to get PET CTs for our patients.
Great. That about does it. Thank you so much.